Welcome, everyone. Thank you for attending today's session. So I'm going to start off with a clinical case of a 55-year-old patient who presented with mild abdominal distension. Physical exam and CT scan was consistent with the pelvic mass. Her CA-125 was 80. She went to surgery and was found to have a stage 1A low-grade serous carcinoma of the ovary. And at that time, no further treatment was given. Her CA-125 post-surgery dropped down to 12. 5 years later, she presented with some symptoms, some abdominal distension, discomfort, and was found to have an elevated CA-125 of 180. CT scan at that time showed, intra-abdominal disease with omental masses and peritoneal disease. She underwent surgical cytoreduction and had a complete resection with no evidence of residual disease. Pathology was consistent with advanced low-grade serous carcinoma, and ER was positive at 75%. So first question is, how would you treat this patient post-surgery? A, carboplatin paclitaxel followed by an aromatase inhibitor as maintenance. B, carboplatin paclitaxel without AI maintenance. C, carboplatin alone. D, aromatase inhibitor alone. Or E, would not give any systemic treatment since she had no evidence of residual carcinoma. So yeah, correct. That's what I would have done. I think certainly carboplatin paclitaxel followed by an AI maintenance is the correct answer. So I'll take my slides back. All right, so this paper in JCO back in 2017 was practice changing for me. And at that point, this was a retrospective data from MD Anderson that Dr. Gershenson collected for basically patients with stage 2 to 4 low-grade serous carcinoma post-chemotherapy. This was a mix of patients receiving hormonal therapy, some tamoxifen, from most aromatase inhibitors, showing a progression-free survival benefit regardless of residual disease status for an aromatase inhibitor. There was even a trend towards an improved OS benefit. And you heard Dr. Fader's presentation, and Dave O'Malley will go over more of the NRG GY019 that she presented earlier during this conference. So the same patient, so yes, she received 6 cycles of carboplatin paclitaxel. CT scan at the completion of treatment showed some small calcified peritoneal implants and nodes, and you can see on the upper CT image, she had a periportal calcified node, and on the surface of the liver, a calcified implant as well. Her CA-125 after 6 cycles drops only to 55. But then she starts letrozole, and her CA-125 further drops and eventually normalizes to 18 over the next 6 months. She did well for 3 years on letrozole, but then her CA-125 was found to be elevated at 70. She noted pelvic pain and some change in bowel movements. CT scan shows a pelvic mass, which you can see on the right. All the other peritoneal sites, the ones I showed you before, the little nodes, were all stable. Physical exam was consistent with a fixed pelvic mass. MRI scan really showed that this cancer was more invasive in the pelvis, invaded into the presacral space, pelvic sidewall, and piriformis muscle. So she was deemed to be inoperable. So how would you next treat this patient? Okay, so the most answer was pelvic radiotherapy. She was changing, 39%. Some folks would go back to carboplatin paclitaxel, few years. PLD Bev changed to another AI. That one I'm not as excited about. Fulvestrant, is a big pelvic mass, as you saw on the scan, MRI, and she's symptomatic. So I'm not sure how much a repeat of another hormonal therapy, but certainly I think probably the first 3. My concern would be making sure that if you're going to use Bev, that she doesn't really have any bowel involvement. You'd really want to make sure about that. Okay, so yes, she received pelvic radiation therapy with decrease in the size of the pelvic mass and resolution of her symptoms. She then transfers her care to you, and you order sequencing, next generation sequencing on her cancer, and a KRAS G12V mutation is found. TMB is 2.4. You also check other biomarkers, HER2 0 via IHC, and folate receptor alpha is 15%. So now this is 2023. So after radiation, she did well for 1 year. She presents in 2023 with a CA-125 that starts to rise, And a CT scan shows an increase in the size of her calcified peritoneal implants. So what would you do next for this patient? All right, trametinib, MEK inhibitor. I think that is what exactly she received. Really, she's asymptomatic, but the HER2/5 is going up, so maybe not necessarily needing chemotherapy. So I'm going to go into this. So this is taken from a table from one of my colleagues' reviews in Gyn-Onc on basically targeting the RAS-MEK pathway in low-grade serous ovarian cancer. And the red box shows you the results of different trials of MEK inhibitors. Some of these are randomized trials, but I've basically made the red boxes what is pertinent for this lady. So selumetinib was studied by Dr. Farley many years ago, more than a decade ago. And in this trial, interestingly, the KRAS mutated patients had a lower response rate than the KRAS wild type. Dr. Gershenson in Lancet published MEK inhibitor versus investigator's choice treatment, and really showed pretty definitively that the KRAS mutated patients had a 50% response rate to trametinib starting at 2 milligrams a day versus and this was superior to investigator's choice treatment. The mutation absent patients had a much less response rate. Brad Monk with binimetinib, you're on that paper too, right? Yes, we've got, yes. Dr. Grisham is part of that trial. Showed that binimetinib had for a MAP kinase pathway altered cancer, pretty good response rate, 41%, very comparable to Dr. Gershenson's. And then this last paper is really a MEK plus a PI3 kinase inhibitor. It was a pretty toxic regimen, only overall response rate of 12%. That's from Becca Arend. So yes, the patient in fact starts trametinib 2 milligrams a day. The dose ended up being reduced down to 1.5. Sometimes I'll even start at 1.5 and see how they do, but this patient was started at 2. And because of facial rash and some diarrhea, that's why you ended up reducing the dose. But she tolerates the 1.5 milligram dose well. After being on trametinib for about 8 months, her CA-125 starts to rise. And a PET CT scan shows now increase in peritoneal disease, but also she develops new mediastinal adenopathy, and you can see that on the chest PET image here. So, what's the next best option for management of her disease? All right, so 84% of you said avutometinib and defactinib. Rachel had a great presentation on Friday about this combination, and I'm going to talk a little bit about it, but certainly I think I'm glad nobody increasing the dose of trametinib. I mean, it's a really excellent drug, but the toxicities are really diarrhea and that rash. There's really not a paradigm for adding Bev to trametinib. Dave, is there a paradigm for adding Bev to trametinib?
Not that I know.
No. Okay. All right. I didn't think so. And then I think, pegylated liposomal doxorubicin, Dave Gershenson mentioned that as one of the possibilities. But I think, this is a lady with a known KRAS mutation. So with the data that Rachel presented, that's a very compelling next option. We'll talk a little bit about, I have a couple of slides on dabrafenib and trametinib, but that's not appropriate because she doesn't have the correct mutation here. So avutometinib and defactinib, so this is what Rachel presented earlier in the meeting. Avutometinib is a RAF-MEK clamp, as you can see on the left. And it also blocks the compensatory pathway of reactivation by MEK. Defactinib is a FAK inhibitor, so it's blocking a separate pathway, and also blocks the compensatory reactivation of MEK. So very unique mechanism of action. So this is the original paper from Rachel and from Susie Banerjee, published in the JCO. Now a year ago, 2025, but a year ago, yeah. Really showing the efficacy, initial efficacy of this combination, both in KRAS mutated patients as well as patients with low-grade serous carcinoma recurrent that did not have an underlying RAS mutation. And Rachel presented the 1-year update to this. And in the red box, you can see, and that really represents the patients who have underlying RAS mutations, KRAS mutations specifically, not NRAS, not HRAS, but KRAS specifically. 44% overall response rate. And then for the wild type patients, not zero response, 17%, but much, much less. And that's where the accelerated approval came from the FDA using this drug regimen, both oral drugs for KRAS mutated patients. These next two slides I borrowed from one of my colleagues, Elizabeth Stover, showing really the amount of RAS mutations in ovarian cancer. KRAS, NRAS, BRAF, and HRAS. What we're looking at is in blue, that's low-grade serous carcinoma, and you can see about 30% of patients have an underlying KRAS mutation. You'll definitely find NRAS, but that is not covered, at least currently, by the accelerated FDA approval. And then when you dig a little deeper into, okay, so we've got KRAS mutations, what kind of KRAS mutations they are? Most of them are G12V and also G12D, and that's on the left. We do have drugs targeting G12C, and that's adagrasib and sotorasib, but that's not applicable. They're not FDA approved for our patients in G1 cancer, more lung cancer. So we can't really use those medications. So Rachel on Friday presented the 1-year update on this, on the RAMP trial, showing that the duration of response continues to be really remarkable. So 31.1 months for patients receiving this doublet who have an underlying KRAS mutation. And then the median progression-free survival was 19.6 months. The RAS wild-type patients also had excellent results, but it's really the KRAS mutated patients that really are showing this really superior results. This is also taken from Rachel's presentation, the treatment duration and response time in patients with KRAS mutated tumors. So on the right kind of summarizes this data that the median duration of treatment, so that's not necessarily response, but of treatment, was 12.6 months. The median time to response was about 4 months, so this is not chemotherapy. These are really a unique mechanism of action. And this is also low-grade serous carcinoma, which is, as Dave Gershenson mentioned, it's a slower tumor. And then over half of patients remained on therapy for more than a year. I think another interesting feature of the presentation on Friday, and certainly something that I've seen in practice, is that circulating tumor DNA does not necessarily pick up a KRAS mutation from a patient with a low-grade serous carcinoma. And I'm just circling the red box. So in patients with KRAS mutations that are detected in tumor samples through sequencing, 44% showed a KRAS mutation in blood samples, and 56 did not. So you cannot rely, I don't rely on circulating tumor DNA to make this decision, and we definitely found that out in some of the trials for RAS inhibitors. You had to really prove the patients have a RAS inhibitor, and you can't always see that. You can see it on an old tumor, but most of these trials require fresh tumor. Then you have to do a fresh biopsy to prove that that KRAS mutation is still there. So the patient starts avutometinib and defactinib in September of 2025. And on the right, you're allowed to do that now because of the accelerated FDA approval on May 8th of 2025 of avutometinib, defactinib for RAS mutated low-grade serous carcinoma. The dosing for avutometinib is 3.2 milligrams orally twice per week on day 1 and 4, and then the defactinib is given as a continuous dosing for the first 3 weeks out of 4. So her CA-125 drops down to 25, and imaging was consistent with a response, and she has experienced asymptomatic elevated CPK, and also had a mild facial rash treated with topical steroids as well as doxycycline. And she currently remains on avutometinib and defactinib.